Hey, Chairman Littlewood, how are you doing?
I'd like to call the House Health Committee to order. Will the clerk please take the roll?
Representatives Alexander, Boyd, Byrd, Clemens, Freeman, Gant,
Here.
Hakeem, Hall, Helton, Hicks, Jernigan, Kumar, Marsh, Mitchell, Ramsey, Sherrill, Vaughn, Whitson, Williams, Vice Chairman Leatherwood, Chairman Terry.
Here.
Mr. Chairman, you have a quorum.
All right, thank you. And before we get to the calendar today, do any of the members have any personal orders? All right, seeing none from the members, I would like to mention today is Tennessee Association of Nurse Anesthetists Day on the Hill. And we have some CRNAs and student nurse anesthetists in the audience. So if you would welcome them. All right, we have a pretty robust calendar, so we will go to item number 1, House Bill 2667. Chairman Vaughn, you are recognized.
Thank you, Mr. Chairman. I
You have
hope you don't
motion and
mind if I
second.
take the convenient way out and sit here and to present this bill. Folks, this bill is brought by the Tennessee Hospital Association to address their staffing crisis. We're hearing about it every day. We know that it's real. We hear anecdotal evidence of it. And so what this bill proposes to do is to allow the Commissioner of Health to declare a state of emergency for staffing. But first, I have an amendment that rewrites the bill, Mr. Chairman.
Okay, amendment number, is it 015223?
Yes, sir.
Okay, I need a motion.
Second.
You have a motion and a second. You're recognized.
And what this amendment incorporates is clarifications to the original bill that's been brought to us by the Department of Health, the DIDD, and the Tennessee Healthcare Association, who is senior living folks. So they've added some commentary and some amendments to it that we consider to be friendly. But going back to the purpose of the bill is the commissioner's allowed to declare a healthcare emergency or healthcare staffing emergency. And what that would trigger would be the ability to allow healthcare professionals licensed in another state to temporarily practice here in accordance with our scope of practice rules. It would allow for licensed professionals to temporarily practice outside their scope within a hospital setting, allows student nurses to participate under direct supervision, and also allows the Commissioner of Health to temporarily suspend rules for healthcare facilities with regards to directives called for by CMS. And the Commissioner can place geographic and time limits on each of these, and the healthcare emergency requires the Commissioner to notify not only the Governor, but also the Speaker of the House and the Lieutenant Governor. And with that, I'll answer any questions folks may have.
All right, any questions on the amendment? Okay, seeing none, we are voting on the amendment. It is 015223. All those in favor say aye. Aye. Opposed? Ayes have it. Okay, we are on the bill as amended. Do we have any questions for the sponsor of the bill? Okay, question's been called on the bill. Without objection, we are voting on House Bill 2667. All those in favor say aye. Aye. Opposed? Ayes have it. Bill goes on to government operations. Thank you. I have spoken with the sponsor of the next bill. We do have a pretty robust calendar here, and this bill has some testimony on that. So in order to go through our calendar, we are going to roll House Bill 1871 to the hill of this calendar. And we will get to this bill. That brings us to House Bill 2058. Leader Gant, you're recognized. You have a motion and a second. There's an amendment 015183. Is that correct?
That is correct, Chairman.
I need a motion. We have a motion and a second. Okay. You are recognized.
Yeah, do we want to go ahead and put the amendment on in it because it makes the bill and then talk about it?
We certainly can. Without objection, we are voting on amendment 015183. All those in favor say aye. Aye. Opposed? Ayes have it. We are on the bill as amended. You're recognized.
Thank you, Chairman and Committee. This legislation adds smokeless nicotine products to the list of products for the age 21 prohibition under the Prevention of Youth Access to Tobacco, Smoking Hemp, and Vapor Products under the Trump administration. And the amendment, what it does is, with the adoption from the Department of Health, the definition of smokeless nicotine products will not include nicotine replacement therapy products. These products will remain available to persons 18 and up, used to treat tobacco use disorders. And with Mr. Chairman, I move passage.
Any questions for the sponsor of the bill? Okay, seeing none, we are voting on House Bill 2058. All those in favor say aye. Aye. Opposed? Ayes have it. Bill goes on to calendar and rules.
Thank you, Chairman.
Thank you. That brings us to item number 4, House Bill 1686. Chairman Williams, you're recognized. You have a motion second.
Thank you, Chairman and members. I do have an amendment. I know the members may have forgotten, but I haven't, that I tried to move this bill last week for about 12 minutes before people reminded me that we were rolling it for a week. But did we adopt that amendment last week?
We did not.
Okay, so the amendment, drafting code 013884, and it rewrites the bill.
Okay, you have a motion and a second. Without objection, let's get that on the bill. All those in favor say aye. Opposed? Ayes have it. We are back on the bill as amended. You're recognized.
Thank you, Chairman and members. House Bill 1686, as amended, would create a pilot program for the next 3 years, which would extend respite care to families who care for their loved ones who have been diagnosed with Alzheimer's. As many of the body may know, my grandmother passed away from Alzheimer's several years ago after an 8.5-year battle. What this bill would do is, much like my aunts didn't have, it would allow for 3 to 4 hours a week for 150 families across the state in the 3 grand divisions to allow for respite care so that they could care for their own selves and families while, and this pilot program would work a lot like the Choices program that we currently have, with the idea that if with this kind of respite care, these loved ones could care for their family members in their homes for longer period of times, which would keep them out of long-term facilities, which costs dramatically more than someone staying at their home. This bill is actually named after Colonel Thomas G. Bowden, his wife, and it looks like one of her daughters are here today in the audience. His wife is here. I got to know it's not his daughter, but they do have a couple daughters. But anyways, this bill is here to recognize him. He served our nation in the military and most recently passed from Alzheimer's. I'm happy to answer any questions that the members have. This bill, as amended, the difference between the original bill and this bill is that it would be administered by the AAADs. If you have any questions, I'm happy to answer.
Thank you. Chairman Whitson, you're recognized.
Thank you, Mr. Chairman. And Chairman Williams, I do appreciate this also, that you carrying this bill. My mom passed away from Alzheimer's 3 days before I was first elected. And we have folks suffering from Alzheimer's, but also the family members pay a heavy price. And it was really tough on my dad. And that's why this bill is so important. But I also would like to recognize Barbara Bowden in our audience, as Chairman Williams did, and just a little bit about her service and her husband's service to the Army. Colonel Tom Bowden from Tullahoma, Tennessee, graduated from MTSU in 1972, was commissioned in the Artillery Corps through the ROTC program. Colonel Bowden ended up commanding all the Persian missiles, nuclear missiles in Europe, and brought about the fall of the Berlin Wall by his action in his unit. And Barbara, we appreciate your service to our Army and to Tom. Thank you.
Thank you. Any further questions for the sponsor of the bill? Okay. Seeing none, we are voting on House Bill 1686. All those in favor say aye. Aye. Opposed? Ayes have it. Bill goes on to government operations.
Thank you, Chairman and members.
Thank you. That brings us to item number 5, House Bill 2858. Chairman Kumar, you're recognized.
Thank you, Chairman.
Need a motion? You have motion second.
House Bill 2858 is a technical correction to the almost omnibus bill that we passed, HB 9077, last year towards the end of the session. It corrects the term or eliminates the term condition of participation that imposes a, because this phrase in the CMS regulations applies to hospitals only. And because of the late night hour at that time, it got included in the physician part also. And this is to streamline things and avoid confusion in the code. And for that reason, these words are deleted.
Okay. Okay.
Thank you.
Thank you. Any questions for the sponsor of the bill? Okay. Seeing none, we are voting on House Bill 2858. All those in favor say aye. Opposed? Ayes have it. Bill goes on to calendar and rules.
Thank you.
That brings us to item number 6, House Bill 2510. Chairman Kumar, you're recognized.
Thank you, Mr. Chairman. House Bill 2510 clarifies.
I need a motion. You have a motion. Second, you're recognized.
Clarifies that an international medical school graduate applying to practice medicine in the United States must provide evidence of satisfactory completion of a 3-year postgraduate training program instead of a residency program. And it lists the satisfactory completion of the program, that the program is an approved program for the purpose of training these graduates. With that, I renew my motion.
Okay. Any questions for the sponsor of the bill? Seeing none, we are voting on House Bill 2510. All those in favor say aye. Opposed? Ayes have it. Bill goes on to calendar and rules. That brings us to item number 7, House Bill 2857. Chairman Kumar, you're recognized.
Thank you again, Mr. Chairman. House Bill 2857.
You have a motion and second?
House Bill 2857 relates to the central service technicians. These are technicians in a hospital and other facility setting. They clean, prepare, and sterilize instruments and process them so that they are in good functioning order. It's a skilled technical job, and this bill requires that these technicians shall practice central service work if they have successfully passed a nationally accredited central service exam, a certified registered central service technician credential, and a sterile processing and distribution technician credential. People who were functioning in this capacity prior to 2017 are grandfathered, and those who start new in this field are given 2 years to achieve these credentials. With that, I renew my motion.
Okay. I think there's an amendment that we have that we would, that adds to the bill, Amendment 013847. Is that correct?
That is correct.
Okay, you have a motion and second on that. I think you explained that. So without objection, let's vote on that amendment. All those in favor say aye.
Aye.
Opposed? Ayes have it. We're back on the bill as amended. Any questions for the sponsor of the bill? Seeing none, we are voting on House Bill 2857. All those in favor say aye. Opposed? Ayes have it. Bill goes on to calendar and rules.
Thank you.
Thank you. That brings us to item number 8, House Bill 1903. Representative Alexander, you're recognized. You have a motion and a second. There's amendment that rewrites the bill. 014152. Is that correct?
That is correct.
I need a motion. You have a motion and a second. Let's get that on the bill in proper form. So without objection, let's vote on the amendment. All those in favor say aye. Opposed? Ayes have it. We're back on the bill as amended. You are recognized.
Thank you, Chairman. Thank you, Committee. With the adoption of Amendment 1, this legislation is intended to clarify that continuing education courses taken by dental hygienists that are conducted via live interactive webinar are to be considered at an in-person event. Dental hygienists are only allowed to receive 1/2 of the required 30 hours of CE via online or web-based courses. This legislation is intended to allow interactive web-based courses to count as an in-person event. An interactive webinar would be one conducted via Zoom or Teams, where the instructor can interact via voice or chat with the hygienist. The Dentist Association, as well as the dental hygienists, both approved this bill.
All right, thank you. Do we have any questions? Okay. Chairman Ramsey, you're recognized.
I'd like to thank the sponsor for this bill. This is very efficient for the use of time. Over the pandemic, several states had waived issues with continuing education. And so it turned out that online education turned out not to be face-to-face. And so that caused some people some real issues. So I appreciate you bringing this bill. It's very good help and probably will be used in some of the other professions.
Right.
Thank you very much.
Thank you.
All right, any further questions for the sponsor? Okay, seeing none, we are voting on House Bill
193.
1903. All those in favor say aye.
Aye.
Opposed? Ayes have it. The bill goes on to calendar and rules.
Thank you.
That brings us to item number 9, House Bill 1917 by Chairman Whitson. You are recognized. You have a motion second. And there is an amendment that rewrites the bill.
Yes, Mr. Chairman, I show the amendment number 13748.
Okay. You have a motion and a second. Since it rewrites the bill, let's get that on the bill. All those in favor say aye. Opposed? Ayes have it. We are back on the bill as amended. You're recognized.
Okay, thank you, Mr. Chairman. House Bill 1917 gives licensed behavioral analysts, the authority to administer behavioral scales within the scope of practice of applied behavioral analysis. The results of these scales must be used only to guide treatment and monitor progress of treatment. Results may not be interpreted for a diagnosis. With that, Mr. Chairman, I renew my motion.
All right. Any questions for the sponsor of the bill? Seeing none, we are voting on House Bill 1917 as amended. All those in favor say aye. Opposed? Ayes have it. The bill goes on to calendar and rules.
Thank you, Mr. Chairman and committee.
Thank you, and I appreciate the indulgence of the committee and the sponsor of item number 2. That brings us to the heel of the calendar. We are on House Bill 1871 by Chairman Halsey. You are recognized. You have a motion and a second.
Thank you, Mr. Chairman, and thank you, committee. This bill has an amendment on it, or amendment proposed to it. If you want to put that on the bill before we go further.
There are 2 amendments that are presented or that were filed by a member of this committee. And if they're a friendly amendment, we can do that now. That would be a proper thing for us to do. Which amendment do you have that you would like us to consider?
014913.
Okay. We have amendment 014913. Chairman Kumar, you're recognized. I will need a motion and a second for that. You have a motion and a second. You're recognized.
Thank you, Mr. Chairman. I really want to thank Chairman Halsey for us to work together. I think that makes things better, and he's been most generous about it. The bill in context basically asks that natural immunity be recognized as a legitimate form of defense that the body has. And it is an effective way for the body to resist infections. This amendment adds the fact that the presence of natural immunity will be documented by a physician's note, letter, or measurement of sufficient antibody levels in a blood test.
All right. Do we have any questions for the sponsor of the amendment? Okay. Any comments from this is a friendly amendment?
Yes, sir.
Okay. All right. Okay. Without objection, we are voting on amendment 014913. All those in favor say aye.
Aye.
Opposed? Ayes have it. Okay. We are back on the bill as amended. You are recognized.
Thank you, Mr. Chairman. The bill's pretty straightforward. It says that natural immunity is as good or better than the COVID-19 shot. And that's the whole substance of the bill, and that's what it says. And with your indulgence, Chairman, I have three doctors here who would like to briefly speak to this issue. Dr. Ryan Cole, Dr. Robert Malone, and Dr. Denise Sibley.
All right, without objection, we will go out of session to hear the testimony. Thank you for coming today. If you can please just tell us who you are and who you're with. And for the panel, we'd ask that you keep your comments to 3 minutes, and then there may be questions from the panel or from the committee. You're right.
Thank you. Thank you, Mr. Chairman and representatives. My name is Dr. Denise Sibley. I'm an internal medicine board certified physician from Johnson City. I've treated over 4,400 patients for COVID over the last 23 months. I've done so without any financial benefit, and I come here without any financial conflicts of interest or any conflicts of interest. I work for myself. This is something I'm very passionate about as someone who's actually COVID recovered myself. As you can see, I call myself a walking comorbidity, and I'm here alive because of treatment. So I've treated many, many different patients who have recovered, including an HIV positive patient, a organ transplant patient, a 99-year-old, a 500-pound person, and my elderly parents who are 88 and 90. So I've treated a wide variety of patients. And the idea that immunity that you acquire from a disease has been a centuries-old part of medicine. This was even recognized before germ theory. Back in the 1300s, when the Black Plague came through, the people that had recovered from the Black Plague were allowed to carry out the bodies of those who had recently passed away. So they even recognized back then that once you had the disease, you were immune. Suddenly, in this COVID era, that changed so that the definition of immunity was changed to only include a vaccination. I will also say that for myself and other people who are COVID recovered, to mandate a vaccine is to experience increased adverse events. That is, if I was required to get a vaccine, I would have a 2 to 4 times chance of increasing my risk of an adverse event. And I will introduce you to my friend, Nikki, who did not have COVID, but she did experience an adverse event from a vaccine in her primary series. And I would be experiencing 2 to 4 times that risk. This is real, and this happens. I have over 500 vaccine injured patients in my cohort. So this is something I'm very passionate about. And as a healthcare worker, I think that natural immunity should be recognized. Thank you. Thank you, Chairman.
Thank you. Have another, is that the end of all the panel's comments, or you'd like to testify?
Let's see if I've got the mic working. My name is Dr. Robert Malone. I'm a Maryland licensed physician. I'm also a scientist. I'm here representing the International Association of Physicians and Medical Scientists, which is over 17,000 physicians and scientists. I serve as the president. I also serve as the Chief Medical and Regulatory Officer for the Unity Project, based out of California. We're an association of many, many other organizations that are opposed to vaccine mandates, particularly for children. I also happen to be the person who originally invented the mRNA vaccine technology between 1987 and 1989. I support that assertion by the basis of 9 issued U.S. domestic patents and many international patents. I have over 30 years of experience as a vaccine developer. I work closely with the federal government, particularly the Department of Defense, but often sit on study sections or chair study sections for the NIH and NIAID. I'm particularly noted as an expert in biodefense and have either won or managed over $8 billion in federal grants and contracts. I'm here to speak to this issue of natural immunity, and I'd like to mention just 4 key points. First off, regarding natural immunity and vaccine-induced immunity, as someone who is a specialist in the technology and in vaccines, one of the issues that we have with the vaccines that are currently used here in the United States for SARS-CoV-2 or COVID-19 is they produce a very narrow immune response that unfortunately seems to wane as measured by effectiveness in the field. And you know this because of the repeated requirements for vaccine boosters. It's narrow because it's only against the spike antigen. And there are many different antigens or proteins expressed by the virus. When one elicits natural immunity as a consequence, or one, perhaps I prefer the term acquired immunity after infection, what you elicit is a mucosal immune response because that's how you experience the virus, as opposed to the parenteral immune response that's generated from the vaccine. And the immune response is broad-based. It's against multiple different proteins. And so it provides much more robust immunity as measured in the field. And Dr. Cole will speak to this. The second point I wish to make is, as somebody who's been traveling quite a bit throughout this outbreak, I'm very familiar with the policies in the European Union in which acquired or natural immunity is widely recognized in the European Union green card system as equivalent in providing protection for all of the various requirements for access to state buildings, restaurants, etc. Although it's of interest that in the European Union, except for Italy, all of those passport requirements are being dropped about the middle of this month. Third part, natural immunity versus acquired or recovered. I just wanted to mention those terms are somewhat, they're interchangeable. It's the common language that's developed this idea of natural immunity, but more precisely, it's really the acquired immunity as opposed to the term we usually use as innate immune response. That's the immunity that your body naturally has, even if they haven't experienced the virus before. So technically, I prefer acquired immunity rather than natural immunity, but that's a small tick. We are aware, unfortunately, that with the vaccines, the antibody response wanes.
Dr. Malone, you're over your 3 minutes.
I apologize, sir.
Okay. We can get to you in the questions. You have one more person here to testify. You are recognized.
Thank you, Mr. Chair. I'm Dr. Ryan Cole. I'm an MD. I'm a physician, Mayo Clinic trained anatomic clinical pathology, subspecialty fellowship in dermatopathology. I do molecular biology. I've done over 150,000 COVID tests in my laboratory. Much to my chagrin, there's a member of the General Assembly that sent out a false email, defamatory, libelous, slanderous about me. Hopefully you will all get a copy of my CV.
On the bill, please.
All right, thank you. Just so you know, I am who I am. Natural immunity to both Dr. Sibley and Dr. Malone's point is that we have always recognized it in medicine until these last 2 years. Just in the last week, Dr. Walensky of the CDC has finally started soft pedaling and saying, hey, yeah, natural immunity, COVID-acquired immunity is real. That was in a grand round she gave at Washington University, St. Louis last week. We know that a vaccine immunity does not equal a COVID-recovered immunity, for the point that Dr. Malone just brought out, that there are many proteins on the virus, that a vaccine only covers one. COVID-recovered acquired immunity covers all of those. We know SARS-CoV-1 for 18 years and running now, those individuals who had SARS-CoV-1 are still immune to SARS-CoV-1 and interestingly cross-immune to SARS-CoV-2 as well. So people worry about, is this long durable? Absolutely. An acquired natural immunity is long and durable. Studies from those individuals who had COVID early in the pandemic in Italy, in northern Italy, still have immunity. And based on our studies with SARS-CoV-1, that should extend on out in perpetuity for what we know at this point. Interestingly, you know, if you get a shot, you don't make the little antibody mops in your tears, your nose, your throat like you do in infection where the virus enters. So those who've had a natural infection have the ability to clear the virus. Those who've had the vaccine don't have the ability because they don't have these little IgA secretory mops in their ears, the nose, and throat. And that's why we've seen a lot of those who've gotten 1, 2, 3 shots still get COVID because they don't develop a full broad immunity like a natural infection does. So that's a very important just pathophysiological factoid. So basically, your chance of getting COVID and spreading COVID, according to the CDC, in their data, when they were inquired how many people have been shown to have COVID and spread it to anyone else, their answer was they couldn't show one single case. And that was a case by ICANN and attorney Aaron Seary. So those are just my brief introductory comments, and I'm pleased to answer any questions thereafter. Thank you.
Thank you. I appreciate that. And we have some members here that may have some questions. I will ask the first question, and it's to Dr. Malone. You ran out of time. I'd like to hear your fourth point.
First, I have to turn on the microphone. The point has to do with the durability, which is a key issue. And we know that waning immunity has been a major problem with the vaccines, no matter how many boosters you receive. And as Dr. Cole has just testified, the data are very clear that the acquired adaptive immunity lasts for considerably longer than the 60 days associated with the vaccine acquired immunity. I'd also like to emphasize that one needs to be cautious. There is no evidence that neutralizing antibodies or antibody titers are actually an accurate predictor of protection. That seems to be a misunderstanding among many folks. The only measure that we have right now in a regulatory standpoint, and that's one of my core competencies, is actual measured immunity in the terms of the patient not being susceptible to infection. So at this point in time, the fact that antibodies may wane with one or the other vaccine or acquired immunity is essentially moot because it is not predictive of protection. Historically, with respiratory viruses, the protection is afforded by T cells, not antibodies. Over.
All right, thank you. Appreciate that. Leader Gant, you are recognized.
Thank you, Chairman, and thank you all for being here today. And I'm not sure who wants to take this question. I've got a few questions, if you would allow me to, Chairman.
You're recognized.
Is it your professional opinion that the acquired natural immunity, is it more effective than the vaccines that are on the market now? And if so, why?
Thank you, Mr. Chair. And thank you for that question. Yes, if we look at the studies out of Israel and out of Qatar, they clearly indicate that a COVID recovered immunity is much stronger than a vaccinal immunity. And the early Israel studies, and this was on hundreds of thousands of patients, it was about 13 times stronger to have a COVID recovered immunity. In the Qatar study, it was almost approaching 30 times stronger. So we have the data from many studies around the world with good data sets showing that those who have recovered from COVID have a much better, longer, broader, durable immunity.
How long does the vaccine, is there any science or studies that show how long the vaccine lasts versus natural acquired immunity?
Well, that's the challenge with these vaccines. We've seen the number of cases acquired in those who've gotten a shot and still gotten COVID. So early on, it was thought that they would be long lasting. When we found on average, it was only a few months and then waning at that. And with Omicron, we have seen that those who have had a shot or had a booster actually have a higher chance of acquiring Omicron than those who didn't. So we've seen the data out of Denmark, out of Israel, out of the UK, where the shots actually turn into what we call negative efficacy, where your chances are higher from the shots of getting disease instead of being protective.
Sir,
You're recognized.
if I could augment that, sir, in the latest data from Albany Board of Health that's received quite a bit of press and attention, we see evidence of the pediatric population of lack of protection for as short a period as 30 days. So very short duration, or we call it durability of protection associated with the vaccines in key pediatric populations. Over.
You're recognized.
Are there any additional benefits of natural immunity versus vaccine long term?
You're recognized.
Thank you, and that's a great question, and I think that goes back to the SARS-CoV-1 question. And those individuals, if you have a natural infection, you make antibodies and T cell memory broadly to all parts of the virus. Now, when you get a shot, you're only getting about 12% of the virus, the hat of the virus, your head. But in a natural infection, in all diseases, when you see the whole organism, now you have a broad brush painted picture of that organism, and your body says, well, if I can't attack this part, I can attack that or that or that. Not only do you have those neutralizing antibodies, but you also have the Marines of your immune system. They're the first ones in to recognize an invader, and they also form memory, and they attack that whole virus as well. But when you focus on one little area like the spike and it mutates, now, if you have just that vaccinal immunity, you're going to lose that breadth of coverage, but you have a big, broad, strong Marine fighting force if you've had the natural infection, because your body recognizes all those proteins in the entire virus, even if part of it changes.
Sir, if
Dr.
I
Lane, you
may
recognize.
augment that, we use this terminology, mucosal immune response, and it may not mean much to the layperson. What the language means is that your immune system is targeted and it has different characteristics depending on where you first encounter the antigen, the virus. And this term mucosal immunity, what it means is there are particular types of antibodies, Ryan referred to them as secretory IgA, that are produced in the lining of your mucosa, like your nose and your oropharynx. And that's where you get infected with these respiratory viruses first. And so the specific answer to your question, in addition to what Dr. Cole just mentioned, is there's this specific category of antibody that's produced with natural infection that is not produced with the parenteral infection, the muscle shot. And that is key to clearing the virus and preventing you from being infected by the normal route of your nose and your mouth or your eyes as a frequent source. I hope that made sense, sir.
And if I could piggyback on real quick, and studies in Wisconsin, Vietnam, and California showed that those who had gotten the shot in the arm don't make these critical necessary mucosal antibodies. And hence those individuals in those studies that had gotten the shot were carrying equal or higher volumes of virus than those who had not.
Again.
Mr. Chairman, it's my last question, I promise. Help me understand the vaccines that were developed. They were developed under an emergency order, correct? So they did not go through the normal testing and trials that take years. Can you explain that so we can, the committee can have a better understanding of that process?
You're recognized.
Thank you, sir. I'll field this question. I am a specialist both in biodefense, in federal rules and regulations, and regulatory affairs. I've been doing this for well over 20 years. I'm a recognized expert in this area, particularly in emergency use authorization language. What we have is a situation in which, under the understandable fog of war and the need to expedite some immediate response, a series of decisions were made in the White House and in the task force known as Operation Warp Speed. I actually had mentored the now Colonel who was in charge of OWS for Moderna. So I'm very aware of what happened. And it certainly, although the government has asserted that there were no steps taken that normally would be taken, that is not true. As you correctly identify, typically it takes us 10 years and well over $1 billion to take a vaccine to licensure, and it typically requires at least 2 years after completion of the phase 3 trials. In the case of this particular situation, there was a decision by the FDA to allow the vaccine manufacturers to bypass a number of the normal steps that would be required before the product would ever be used in humans, and to minimize the characterization that would be normally performed. A number of these steps include characterization of genotoxicity, biodistribution, what we call pharmacokinetics. So this is how long the material lasts inside your body, and the levels of protein and the levels of the drug that are sustained in various tissue compartments and where it goes. These information have now gradually trickled out, and most recently, there was a major publication in the journal called Cell by a group from Stanford, so impeccable credentials, that demonstrated that although the pharmaceutical company asserted that these RNAs only last for a very short period of time in your body, in humans, it was clearly demonstrated through fine needle aspiration that these RNAs last in the body for at least 60 days. So there's a number of steps that were not taken, which are normally required. And it's understandable. I don't fault my colleagues for wanting to rush something out the door, but now it's 2 years later, essentially. And we do know that a number of those steps were bypassed, and they were now starting to understand, now that Pfizer has been forced judicially to release the 9 pages of adverse events associated with these vaccines, that we're dealing with a much more complex landscape of adverse events than any of us had anticipated, unfortunately. I hope that answers your question, sir.
It does. Thank you, Chairman, and thank you all for being here.
All right, thank you. Chairman Vaughn, you recognize.
Yes, sir, and thank you, Chairman. Thank you all for being here. I'd like to have talked to y'all a few months ago, very much. I was someone who caught early on COVID, first go around. Actually missed some time here. And my doctor and I decided that we were going to try to do a measured immunity testing of antibodies to see if and when they waned, and if and when he was going to suggest that I'd take a vaccine before I'm around a lot more people. And it seemed as if they had a number. He had a number in mind, and I'm not an epidemiologist, nor I'm just a patient that follows my doctor's advice. And it's at some point, about 6 months into it, he said, "Hey, your antibodies have waned to the point where," he said, "you need to start thinking about getting at least taking one of the vaccines." And the premise of this bill is that you can basically get documented that you've had COVID, but with a quantitative waning of antibodies, how is the science available that we can feel good about the fact? And again, I don't know why we're going to have to present something. I mean, I think that's a whole different set of questions. But is the measurable diminishment of antibodies a concern, and does that actually affect your immunity? Or do the T cells that come in that you can't measure, is that what's going to kick? Because I was getting blood test results back, and I was watching numbers drop. And now what those numbers were, I had to assume that he knew what they were. But that's my question. And I'm sorry for the jibber jabbering around, but I'm trying to communicate in stuff that I'm not that smart about.
Thank you. That's an excellent question. And this is a common question. And my answer is generally antibodies, because your antibodies always go down in any infection. If we kept an antibody response level to all the pathogens we're exposed to every day, our blood would sludge. So it would be non-viable for life. So your antibodies levels do go down, but what's important is we have memory cells both in our lymph nodes and in our bone marrow, both B cells that make those antibodies. Those memory cells still exist. And then more importantly, those T cells, which you can measure a subset of T cells that has been activated to SARS-CoV-2. So there is a test that measures for activation specific to SARS-CoV-2 virus. It's a little more expensive test, unfortunately, but it is documentable. The most important thing, and I think, and Dr. Kumar brought this up, is if you've had an infection, you were ill, you had a positive test, your doctor has validated that. In the history of medicine, generally, if you've had a disease and your doctor says, look, you've had that disease, I mean, that's documentation enough, in my opinion, because it does become kind of a rabbit hole of, well, how do we prove this? How do you do that? There's some good lab tests. There are others that are not so accurate. It's a great question. But the clinical data is really, I think, what's most telling. And if you look at the clinical outcomes in individuals that are COVID recovered, and or a handful do get reinfected even if they had COVID. More seem to be getting reinfected if they had the shot and not had COVID. They'll get reinfected after the shot. But the clinical outcomes, especially if you look at that large study out of Qatar, there were no adverse outcomes in the handful of people that got COVID again after being COVID recovered. Whereas in the vaccinated group, there were a lot more ICU admissions and demises. So looking at the broad clinical outcome in recovery of disease is one of the best societal measures of acquired immunity.
Vaughn, you're recognized.
Thank you. And this is just the one follow-up. My wife was tested and determined to have antibodies, yet she never presented a symptom. And so from that standpoint, again, her doctor, my physician said, hey, yeah, you've had it. You've got a period of time here. You can go do whatever is responsible. But for those people who don't present, are y'all against them going to get tested? I'm trying to figure that out because there's a lot of folks walk around that think they're the luckiest people in the world because they've never had it, never caught it, but yet they may have had it and have never presented. So that's my question is what program or should the general society, what's your recommendation for just general society with regards, considering the fact that not every time somebody has this disease, they present with symptoms?
That's a great question. And a lot of people never do present a symptom. And if we look at some antibody studies, take, for example, children in the UK, as of January, 96% of kids through those studies had been shown to already have COVID. Now we can assume based on, now the CDC's data is way behind, but we know hundreds of millions of Americans have had COVID. They said 140 million last week. It's far higher than that, likely, to your point of, asymptomatic individuals. And this was just laboratory data, aggregated from around the country. So great question. There's a set percentage of people that will never get COVID. And here's why. Because we have common cold coronaviruses that are 60% similar to this virus. And so you will, going to that broad natural immunity, because they've formed some antibody memory to these other common cold viruses, may never get COVID at all. Now, is COVID with us still? Will it be endemic? Yes. Are we back down to pre-December levels of infection? We are. So we had this giant Omicron spike. We're back down to take a breath. We don't have a medical emergency anymore, per se. If you want to get tested, the antibody testing is easy. The T-cell testing is more expensive. If you already had COVID, don't worry about it. But if you have that question, yeah, there are laboratories that can do it, and those are measurable.
Can I add one comment to this?
Yes.
The underlying thesis of a lot of this discussion is that this is a highly lethal pathogen. But in the current embodiment, whether or not the original strain was, and like you, I was infected in February of 2020 with the original Wuhan strain, and it affected me deeply. Omicron, as I predicted before Christmas, is acting as a natural vaccine. It's eliciting the mucosal immune response. It's extremely infectious. It swept through the entire population, but fortunately, it's not very pathogenic. Now, it's possible that could change. That's the truth. But right now, what we're dealing with is not a highly lethal pathogen. And we've had a lot of fear that we've all been subjected to over the last 2 years, unfortunately. But we're now in a situation where the currently circulating virus is not highly pathogenic. And furthermore, the vaccines are not protecting against infection, replication, and spread. So I think that I can certainly understand the fear that all of us have and have experienced, and your constituents have experienced. But fortunately or unfortunately, that fear is unfounded at this point in time with this virus, and particularly for your children. They clear this really rapidly for a number of reasons. And so I think a lot of this underlying assumption that we have to be super sensitive about this particular pathogen is unfounded. This is not Delta. This is not the original strain. What's circulating right now is not a highly pathogenic respiratory virus because the virus has shifted where it's infecting. You'll recall, if I can just give you one last thing to kind of help you process. Remember H1N1? I do. H1N1 kind of came in two flavors. There was a version of H1N1 that infected your upper respiratory tract, and that was not highly lethal. There was a version that infected your lower respiratory tract, got lodged in your lungs, and that killed people. That's always been the case. And the original strains that were circulating had that characteristic. They would infect your deep lung, and that's why it took so many of your friends and colleagues. But the Omicron and the ones that are developing off of Omicron have shifted for some reason, thank God. And they're now infecting this part of the airway and your nasopharynx, and they're not highly pathogenic. I hope that helps.
Thank you. Speaker Marsh, you recognize?
Thank you, Mr. Chairman, and thank you all very much for being here. And I'm not near an expert in this, but I would like to ask the hypothetical question is back when you were talking about fear and death and early on, and you, I suppose if you hadn't had the disease, you didn't have the natural immunity. So would you recommend that during that time frame that you did get a vaccine, or would you recommend that you never got a vaccine?
You recognize?
Well, okay, I'm going to catch that one. When I was infected and when your colleague was infected, there was no vaccine, so we didn't have that option. When we did have a period of time when you had a highly lethal version, Delta, and the availability of vaccine, the data demonstrated that for high-risk individuals, it was unequivocal, just as the Great Barrington Declaration authors had recommended, that it absolutely made sense as a risk-benefit ratio. The people that are in those high-risk groups should be vaccinated against Delta. Now, Delta is gone. It was outcompeted by Omicron. Omicron is much more infectious. And like I said, it acts like a vaccine. And so we're no longer in that position then, but there was a period of time when people who were at high risk definitely had a beneficial risk-benefit ratio to receiving the vaccine. That time has passed now, and I think is a good thing. I hope that answers your question, sir.
Thank you. Next on our list, Representative Mitchell, you recognize.
Yeah, thank you, Mr. Chairman. So from that logic, what you just said, though, you know, we've eliminated several diseases. So by your logic there, should we just stop immunizing children for a lot of the diseases that we've almost wiped off the planet? Because, you know, we saw a resurgence of measles and smallpox recently because parents didn't immunize their children. So what do you suggest on situations like that?
You're recognized.
Can you tell me where we had a resurgence of smallpox? That's new news to me.
Well, it was the measles in New York.
Ah, I see.
You're recognized.
And to that question, that outbreak stayed within, if you look at these small outbreaks, they generally stay within that small cluster of that unvaccinated group. These have tended to be certain religious clusters and religious groups, but if you ask for the data to document any spread beyond those groups, you don't see it. But when it comes to SARS-CoV-2, now that we have Omicron here and the vaccines essentially don't prevent you from getting Omicron, this virus has intermediate hosts, meaning the virus can bounce back and forth between animals and humans and animals and humans. So unless you stick a shot in every bat and every pangolin and every deer, the white-tailed deer like to house this virus in their nasal mucosa as well. There are too many animal reservoirs for this kind of virus. There's certain viruses that you're talking about that we've essentially been able to eliminate from humanity. We will never get to COVID-0 because this virus has the opportunity to go back and forth between animals and humans. So this is a basic virology principle behind different families of viruses, and this is one of those viruses where we can never eradicate it for that very reason.
And the director of the CDC has recently acknowledged that in the term that's used, it's again one of these sciencey terms, is that this virus is now endemic and will continue to be so.
You're recognized on this point.
Thank you, sir. I might bring up that there's treatment. Early treatment really works, and I've demonstrated that in my own over 4,000 patients. There are many protocols that we've used for over almost 2 years now. So early treatment is a very, very good alternative, in fact, superior to vaccination. Thank you.
Mitchell, you're recognized.
Yeah, thank you, Mr. Chair. So Dr. Cole, so you wouldn't suggest the vaccine, even when the vaccine was available for the Delta, you didn't want to prescribe that. Did you prescribe anything else to your patients other than to get the vaccine for COVID-19?
You know, in terms of the vaccine, no, I haven't recommended it to anyone because I've never spoken against a vaccine in my life. So, you know, those who've labeled me anti-vax are incorrect. I'm pro-good science. And in this regard, we had a new experimental gene shot with no long-term outcomes. By the time Delta hit, we were starting to see the efficacy of the shot wane and become negative. Same thing with Omicron. In children who have a 0% risk, I would never recommend the shot for a child ever, just like Governor DeSantis did in terms of no healthy child should get the shot. So in retrospect, no. And, you know, a small benefit maybe in some of the elderly, but now my concern is we're seeing those who got multiple shots are dying of, in studies, are dying of all-cause mortality, all other causes at higher rates in that vaccinated group. So my background concern is with a background in immunology, pathology, virology, when I looked at the technology rolling forth, knew the history of SARS-CoV-1, and antibodies forever. You get a shot, you make an antibody forever. A therapy is temporary. You give somebody a therapy, which I did for many patients and helped them and lost not a single patient. That therapy goes away, but that antibody doesn't. It's good at first, but becomes your enemy down the road if it's the wrong antibody.
You recognize.
So you're stating that you did not lose a single patient and you still didn't answer the question if you prescribed anything else. So
yes, I did.
Do you want to restate that you did not lose a single patient?
Yes, I will restate that.
Okay.
I did not lose a single patient. Not a single patient was hospitalized. Not a single patient passed away. Yes, I used ivermectin, hydroxychloroquine, budesonide, fenofibrate, etc.
I've given some liberty here to the member of the committee. And to the speakers. Let's keep this on natural immunity and what they're here to testify on.
Wait,
You are recognized.
yes, but I think the credibility to this committee when he tells us he hasn't lost a patient and there's complaints in the Indiana Board of Medicine, 5 different complaints for the patient dying because they were given ivermectin instead of the vaccine. I think that's relevant to this committee's knowledge.
Sir, I would
you.
like to be made aware of that complaint because there have been plenty political complaints filed against me. But
let's stay
all right,
on this.
thank you. Natural immunity is strong, durable, long lasting. Thank you.
Representative Alexander, you're recognized.
Thank you. This is just a comment, Chairman, if you so allow me. I just wanted to say, Dr. Sibley, thank you. I first sat at your kitchen table and you told me that you had, we're saving about 100 people. And to hear you say, we've made it with 4,500 in Johnson City, that means the world to me. I thank you for your fight, for your diligence, and you faced much adverse problems with the medical community in our area. And I just want to say thank you.
All right. Thank you. Seeing no further questions on this, appreciate you guys coming here. And while we're out of session, I'm going to recognize our legal services, and Representative Hakeem, you're recognized.
Thank you, Mr. Chairman. My first question, I believe I heard from our guests dealing with vaccines that they're required. Maybe they are. I'm not saying that's the case, but can you give me an understanding in the state of Tennessee or nationally, are vaccines required? First question.
Is that a question to me?
Rajul, you're recognized. Rajul Bejoy, you're recognized.
Rajul Bejoy, Office of Legal Services. Under Tennessee state law, a private business, governmental entity, school, or local education agency shall not compel or otherwise take an adverse action against a person to compel the person to provide proof of vaccination if the person objects to receiving a COVID-19 vaccine for any reason. So under this law is 14.2.102A, it prohibits those entities from requiring a person to provide proof of vaccination, effectively prohibiting a vaccine mandate. Now, there are exceptions in the definitions of private business and governmental entity, and those exceptions are tied to the only are tied to various federal mandates. Most notably, the federal mandate that's still standing is the CMS mandate for healthcare employees and other staff members. So those entities are the only entities in Tennessee that have a vaccine mandate.
Representative Kim, you're recognized.
Thank you. It's just one follow-up, Mr. Chairman. For clarity for me, dealing with House Bill 1871, are we saying that a governmental entity or business has to recognize natural immunity as, I guess, just like you would recognize a vaccine?
You're recognized.
Yes, sir, that's correct.
All right. Thank you, Mr. Chairman.
All right, thank you. Any further questions for legal while we are out of session? Okay, seeing none, we will go back into session. Chairman Halsey, you're recognized.
Thank you. I appreciate the comments. I appreciate the time and the investment to be here with these folks, and thank you for your patience with us. And I renew my motion.
Any questions for the sponsor of the bill? Question has been called on the bill. Without objection, we are voting on House Bill 1871. All those in favor say aye. Aye. Opposed?
No.
Ayes have it. Bill goes on to Commerce.
Thank you, Committee and Chairman.
All right. All right, that concludes our business for the day. Without objection, we are adjourned.